It looks like people have started to stop rolling in and requesting to be admitted into this meeting. So let's go ahead and get started. Again, my name is Tia Zeeby. If you have any questions, please go ahead and direct them to me. Rachel Byers is out sick today, so I will be doing the introduction slides. So this is the final session of our fall 2024 MHIDD ECHO series. This series has been designed to support coordinators and care slash case managers in mind. And the topics were chosen by a group of support coordinators. All are welcome, and we're just grateful to have you here for the last session. We are recording this ECHO session for educational and quality improvement purposes. By participating in this session, you are consenting to being recorded. If you not wish to be recorded, please disconnect from this session. Renaming your profile. Please rename your profile to your first and last name, date, job, and organization. For example, John Smith. Or for me, it would be Tia Zeeby. I am part of the IDRPP, and then I am based in Utah. The raise hand feature is helpful if you have a question for the facilitator. That would be me. Or if you have a question for our presenter today, Dr. Paul Stevens. To use this feature, hover over your mouse on the Zoom window to locate the menu at the bottom. Select participants to open the participant window, and then on the participant window, click the raise hand option at the bottom. During this ECHO session, we ask that you please protect individual privacy. When sharing information about another person, avoid using the real first, middle, or last name or any initials. Do not identify any individual's family members, friends, coworkers, email addresses, etc. Please de-identify examples and situations and reach out to a hub team member if you aren't sure. As far as participation goes today, ECHO is an interactive community, so presenters, stakeholders, and community members are all encouraged to communicate and support each other during this session. It really helps it go, it really helps it be more effective and provide a safe learning experience for all. The key components of an ECHO session, there is a community of practice, so the sharing of knowledge, a didactic speaker, and then a case presentation and feedback. There is a survey link at the very, that should have been put out. It is a Qualtrics survey link. We would ask that you fill out that survey upon completion of the session, especially if you are looking for a certificate attendance or CEUs from the Utah Social Work Association. Again, you can earn professional development credits through the Utah Social Work Association for your participation in our IDRPP ECHO sessions. Receive these credits, fill out the evaluation sent to you after you attend the session, and we'll make sure to drop that link at the very end of the session as well again. And if you do not need CEUs, you can request a certificate attendance as well. The iEcho platform is the platform where you'll be able to access all the content from this series. If you have any questions about the ECHO series, please email Rachel Byers at rachel.byers@usu.edu. I'll also drop my name and email in the chat as well. And then you can follow us on Facebook or Instagram at Project ECHO USU IDRPP, or on Instagram at Project ECHO _IDRPP. Today we are very grateful and excited to have Dr. Paul Stevens. Dr. Paul Stevens is an assistant professor. He earned his medical degree at the University of Utah Medicine. He completed the triple wall residency in pediatrics, adult psychiatry, child and adolescent psychiatry at the Warren Alpert Medical School of Brown University. He's an active member of the American Academy of Child and Adolescent Psychiatry and is board certified in psychiatry and child and adolescent psychiatry by the American Board of Psychiatry and Neurology. He works at the University of Utah Bend Mental Health Institute's Neurobehavioral Home Clinic as a board certified adult and child psychiatrist. Dr. Stevens, I'll go ahead and stop sharing, and you can go ahead and share your screen as soon as I'm done. Thank you for your time.
Thank you, Tia. Let me start my lecture. Are people seeing the PowerPoint?
I'm not.
Okay.
No.
Okay, so we're not seeing it yet. Let me change. One, just so nothing yet. Usually Zoom prompts me to share my screen. Should have screen permission. Sorry, everybody. Is that any better? Nope. Okay. How about now?
Yep, it's working now.
Sorry, guys. So I appreciate the opportunity to be here. And thanks for the introduction, Tia. So I'm an assistant clinical professor in the Department of Psychiatry at the University of Utah. And I work at the Neurobehavior Home program, and I'm excited to talk about our program today and hope to encourage a conversation about care coordination for you all. I'm going to give a little bit of additional background information. I believe in the power of shared experience. And I think many of us come from a background of some sort of direct or indirect connection to the developmental disabilities world, which has been the case for me in my life. So I had early opportunities in high school to volunteer for the Special Olympics, as well as a church organization. Met a really dear friend who I'm still in contact with 30 years later. And it sparked my initial interest. While I was in college, I worked at an intermediate care facility, did an ICFID in Provo as a habilitation technician. It's a very eye-opening work experience. Staffing is low. There were, many clients we had direct care responsibility over. There was a running joke for new ground level staff at the ICF. There were bets made about how long new staff would last, given some of the challenges of providing direct care. So, I definitely enjoyed it. It was a very worthwhile job. It added to my interest in going into medicine. So after undergrad, I was fortunate enough to go to the University of Utah for medical school. While a third year medical student and trying to determine what specialty to go into, I actually rotated at the home clinic back then. Worked with Dr. Debbie Builder and Dr. Paul Carbone, who many of you are probably very familiar with, both experts in this field. For my residency, I ended up picking a triple board program, which splits your time. You do 2 years in pediatrics, and then the remaining 3 years is in psychiatry. The capstone of my training was the opportunity I had to work at the Center for Autism and Developmental Disabilities. It's an inpatient child psychiatric unit as part of Bradley Hospital in East Providence, Rhode Island. And I worked there about a year, and it's a very multidisciplinary inpatient setting with child psychiatry, with pediatrics, with speech and occupational therapy. We had an education specialist, we had behaviorists, we had behavioral psychologists. Really a great experience to see treatment for the most acute settings for these patients. In my last year of training, my daughter Lucy was born. So Lucy's now 9, and she has multiple disabilities. She's profoundly deaf. She has vision impairment. She's very delayed. She has an autism diagnosis, an intellectual disability diagnosis. We were able to determine the cause. It's a specific genetic mutation in the CLTC gene. And Lucy also has severe epilepsy. And she's non-speaking and requires total care, has limited to no safety awareness. And so, yeah, Lucy's been joined my life towards the end of my training, right as I was making a decision about a job. And I was fortunate enough to be able to join the faculty back here at the University of Utah in the Department of Psychiatry to work at the home program. And I've been at the home program since 2016. And then this last March, I became the medical director. I do have 2 other children, neurotypical boys, Jonah and Parker. They're quite a bit older than Lucy. So a little bit of personal background. Again, I think shared experience is powerful as we connect with each other and as we talk about these clients and patients of ours. So the objectives for the lecture today are to go over the history of the home program, describe our model of care, and then to discuss collaborative, what it's like to collaborate and coordinate care. You guys are actually already really good at that. I'll share the perspective of how we try to coordinate care in our clinic, and then we'll finish with a case discussion. So the home program was the culmination of a number of different factors, but it was spearheaded by 2 forward thinkers, Josette Dorius and Dr. Scott Stiefel. Remarkably, the home program was created nearly 25 years ago. And so Josette was a nurse manager in a private health plan, and Dr. Stiefel had trained in a triple board program here at Utah and was interested in treating complex patients with neurodevelopmental disabilities. So at that time, there were 2 existing clinics. The first was the Neurobehavior Clinic through Primary Children's Hospital. This included children with Medicaid who had developmental disabilities. And then the second clinic was a state-run clinic for adults with developmental disabilities, more on the psychiatric side of things. So Dr. Stiefel worked in both of these locations. Both of these clinics were financially struggling and really, weren't going to survive. And so the home program came from some structure of 2 existing clinics. But at the time, the Utah Department of Health was looking to develop new programs to reduce costs and improve care for the most expensive populations. And as an example, in 1996, those with developmental disabilities, which were 15% of the Medicaid population, but incurred 37% of the expenses. So big contributions from the Department of Health as well as Primary Children's Hospital Foundation. The department chairs of Primary Children's were really forward thinking in trying to better address complex care. There was also some contributions from the Robert Wood Johnson Foundation. That financial addition was much less, but it validated the pursuit. And so what ended up coming out of this was the merging of these 2 clinics and the creation of home. So HOME is an acronym that stands for Healthy Outcomes Medical Excellence. And it really ascribes to the medical home model of care, which we'll talk a little bit more about. And the HOME program treats across the lifespan. So initially it was called the HOME Project, and now it's the Huntsman Mental Health Institute Neurobehavior Home Program. Kind of a mouthful to say. So the true innovation of HOME was figuring out how to blend funding streams. So there's wide gaps and differences between how mental health care and medical care is funded. And so this was no small task. It was truly innovated in a novel idea, and it's actually something that hasn't really been able to be replicated. Our program will have groups that tour and come from all over the country, and they just haven't been able to replicate the funding stream. And so it really was a novel idea and has been sustaining since that time. So blending these two funding streams meant that there's one Medicaid funding for the program. Within the first 2 years, HOME grew to 120 DSPD clients. Initially, all of the patients were required to have DSPD, and there was a third arm to this. There was a habilitative arm that was to provide group homes, supported living, supported employment, and respite. But that requirement was rescinded because the clinic wanted to increase access to care to people in the community. Because as you're aware, there are many patients with developmental disabilities who don't have DSPD funding or who are on the wait list. Some were on the wait list for many years. I think my record is a patient who's been on the wait list for 30 years at this point. But those patients still need care. So that arm was removed. But one of the artifacts of that really led to one of the additional innovative parts of the program, which was the provision of case managers. And we'll talk a lot more about the case managers as we progress. Due to how well HOME was doing in meeting patient needs and managing costs, Medicaid allowed the program to grow beyond the 120-person limit. And then by 2006, through CMS stands for the Centers for Medicare and Medicaid Services. Through that approval, HOME became a separate HMO. HMO stands for the Health Maintenance Organization. It gained this approval in addition to being a clinical program. So I'm not here to talk about the financial aspect of things, but in short, the HOME program is both a clinic and it's also an insurance. And like I said, the insurance aspect is for another day, or for Karina Rasmussen, who's the director of the HOME program. She would be better able to dive into the insurance piece. To talk a little bit about clinic location history. So both of the first two locations were in Research Park next to the University of Utah. The first being at the ARUP building, and that was from 2000 to 2005. But as that space was outgrown, they moved just down the road to 650 Comus. And that building, the clinic existed in that building from 2005 to 2019. We had a good chunk of most of the second floor in the Comus building. The lower right picture is the waiting room and the front desk there. The clinic location, there was some strategy there. Both of those first places were, in close proximity to the Neuropsychiatric Institute, or UNI. The new name for that is the Huntsman Mental Health Institute. So the standalone psychiatric hospital, it's associated with the University of Utah. So it was nice having that close proximity. We're somewhere else now and we've lost that closeness, but I think it's been better for patients because it's a little bit more central of a location. So in 2019, our contract was up at 650 Comus, and we ended up finding this building in South Salt Lake. It's a Morris Avenue building right next to the South Salt Lake City Center. So we're on the 4th floor, Suite 400, and it's a much better centrally located clinic in this, in Salt Lake. It's right off of Interstate 80. It's very close to Interstate 15. You get off the State Street exit. It's a little bit, you have to take the frontage road. And so when patients are first coming here, sometimes they end up back on I-80. It takes a little bit, to get to the parking lot. But I do think there's better access as opposed to having to drive all the way up the hill or taking Foothill Drive, which, is not a small task. It's very, very busy traffic wise. So, interestingly, this entire 4th floor was remodeled, and then we moved in the fall of 2019. And then, as everybody is aware, in spring of 2020, our lives got flipped upside down with the COVID pandemic. So we hadn't been able to utilize the clinic in its fullness, but have slowly, reintegrated since 21. And we do still split a lot of our visits. We have a lot of virtual appointments as an option for patients, which adds convenience. And also, I think it's necessary for some patients who don't tolerate in-person appointments very often. But we really like our space. I think my patients, interestingly, love looking out the windows and seeing the cars that drive by I-80. There's something to that stimulation that paradoxically, I thought they wouldn't like the noise, but it's actually kind of soothing. Okay, so the home program fits into the larger University of Utah system. So technically it's a clinic through the hospital and clinic side, through UHealth, through the Huntsman Mental Health Institute, and we're one of the outpatient clinics. But the other arm to the home program is through the School of Medicine, which is how most of the physicians and faculty are hired and develop and work through. So I'm an employee of the School of Medicine through the Department of Psychiatry, and then the pediatrician and family medicine providers are through their own respective departments. We have a lot of trainees across disciplines. So from the School of Medicine, from the School of Occupational Therapy and Speech Therapy, we have URLEN students. So that academic side really funnels a lot of trainees and also the faculty who work here. The rest of our staff are employees of the hospitals and clinics, but really the home is best set for an academic setting. And, like I was sharing in my bio, 15 years ago, I rotated as a medical student and was enamored by the program, and luckily had a chance to come back and work here. Okay, moving on to program eligibility. So it is complete reality that all patients must have Utah Medicaid in order to be eligible for the home program. We are a Medicaid contracted clinic, and so we can only take patients with Medicaid. I know that does, reduce access to patients in the community with developmental disabilities that have commercial insurance. And I think the system is still struggling to figure out how to better serve that patient population. Second requirement is a developmental disability. And, due to our limited resources, we are to the point of requiring prospective enrollees to submit documentation of their prior diagnostic testing. So it's typically administered by a neuropsychologist. Although some other professionals can administer the ADOS, which is one of the gold standard tests for autism. And then certain genetic conditions receive automatic qualification like Down syndrome, because all individuals with Down syndrome also have cognitive, intellectual impairment. And then there is a cohort of traumatic brain injury patients who have devastating cognitive impairment as a result that are qualified for home. But nowadays we do require the documentation to be submitted and to go through a committee to be approved for the wait list. The third requirement is a mental health or behavioral concern. That's a fairly loose or non-specific one, I think for good reason. The next requirement is a willingness to receive all of their primary care at home. And that can be a big adjustment and can be a big hang up for some patients, rightfully so. There's some incredible primary care physicians, both from the pediatric side and family medicine and internal medicine that really have taken these patients under their wings for many years. But that is a reality. We do require that all of the care be done in our clinic. The patients also agreed to receive all of their talk therapy here, but they're not required to have all of their behavior treatments here. Patients can have an ABA therapy, an ABA provider that they receive treatment with, and they can continue with those providers when they enter home. Really, our emphasis and where I think we excel is treating the most behaviorally and psychiatrically complicated patients in our community. So sometimes on the higher functioning side, patients on the higher functioning side may not, may find good services or good therapists or good primary care providers outside of home, and they choose to maintain those services, and we support that. Okay, looking at enrollment. So this graph shows the enrollment from 2005 until the end of this last year. So our enrollment has been fairly steady, although there was an actual dip in enrollment from 2011 to 2012. And I'm not entirely sure why. Certainly our ability to take on more patients is often directly related to our provider situation. How many providers across the specialties on the psychiatry, on the primary care side. And as of the end of this last year in December, home had enrolled 1,520 patients. Our total enrollment was 1,520. Okay, this is also an important slide. We have a catchment area. This was not always the case, but back in 2017, due to demand, Medicaid, who again, we are contracted, they are our contract, they have restricted our catchment to the 7 surrounding counties around Salt Lake City. So this includes Weber, Davis, Salt Lake, Tooele, Utah, Wasatch, and Summit counties. And at this point, it is an absolute requirement. However, if a patient is already enrolled and they lived outside of the catchment area prior to 2017, in most cases, they've been allowed to stay. If a patient moves outside the 7 counties, then they are disenrolled. We do try to help facilitate transfer care to other health and mental health centers in the state. Of note, 80% of the population in Utah is within these 7 counties, so it does still serve a majority of Utahns. But that is a really important thing to keep in mind. The next slide is a little bit about the characteristics of our patients. So 68% are male, 32% are female. And then our age groups, a vast majority are 18 and older. I think in part, our biggest enrollee age range is the transitional age, probably just because it's really hard to find adult providers for these patients. but we do still have, close to 250 pediatric age patients. In terms of the spectrum of intellectual disability, it's, from mild to moderate to severe to profound. Again, about over half of our patients have profound intellectual disability. And then this may or may not be associated with autism spectrum disorder. The other 20% of our patients have likely autism spectrum disorder without accompanying intellectual impairment, or the traumatic brain injury patients with cognitive impairment would fall under that percentage as well. So, and then our payers, about 40% of our patients have only Medicaid. Close to a similar percentage have Medicaid and Medicare. And then about a quarter of the patients have Medicaid and a commercial insurance. Again, the absolute requirement is for Medicaid, but you can have other insurances as well. So, and then the smallest percentage have all three: Medicaid, Medicare, and commercial. One brief note about, the requirement for Medicaid. So, and it might be, and it's another reason why many patients join during the transitional age. So if a patient prior to 18 has a primary insurance only, when they hit 18, they're able to apply for Social Security, which then entitles them to Medicaid. So that's where then patients who didn't prior meet criteria then do meet criteria. So our model of care is really built on three pillars: primary medical care. It's a picture of Barbara Faust. She's a pediatric nurse practitioner who's been in our clinic almost 25 years. Sadly, she'll be retiring in a few months, and we're gonna really miss her. That is one thing we often find in our clinic, that providers are here for many, many years, sort of adding to, I think because it's a great place to work and because there's a shared purpose in treating patients with developmental disabilities. The second arm of treatment is the mental and behavioral health services. That was one of our former case manager's dog, Sunny, who regularly came around the clinic and provided great joy and comfort to many patients. The third arm of our program is case management. Okay. As I said earlier, the philosophy of the home program really tries as closely as possible to align with something called the patient-centered medical home. So that's a really important healthcare construct that aims to provide exceptional care with the goal of maximizing outcomes and focusing on prevention. It's a really important standard and one we try hard to follow. So principles of patient-centered medical homes include that the care is comprehensive, it's coordinated, it's accessible, that the program has quality improvement measures and safety measures in place. We do have a mission statement. Home's mission statement is to optimize the quality of life of people we serve by providing excellent, compassionate, and integrated health services throughout the lifespan. Again, we provide continuous services. You get to keep seeing providers even when you might have to switch from a pediatrician to a family medicine physician between 18 and 22, but you stay in the clinic. And psychiatrists generally don't transition services. They treat across the lifespan. A couple of other elements of a patient-centered medical home include being culturally sensitive and compassionate. So a little bit more into the three pillars. So our case management team, this group of staff really are the communication facilitators. They speak to family within the clinic and outside the clinic. They speak to specialists on the outside. They coordinate and speak to hospitals and other community agencies. We have 8 case managers, and then we have 1 nurse case manager. They follow things such as inpatient psychiatric hospitalizations or inpatient medical hospitalizations, among other things. So our medical team includes a pediatrician, an advanced practice nurse practitioner, multiple family medicine physicians. We have a dietitian, an occupational therapist, and now two speech therapists. And they're, these providers, provide outpatient visits. Patients can get immunizations and shots. They can get their blood drawn. We can do EKGs. Our speech therapist does swallow evaluations and then also can do functional communication treatment. Our occupational therapist has evaluations and sessions. And then we also do have a multidisciplinary feeding team. Our behavioral health, many of our psychiatrists are actually triple board trained. I think in part because the University of Utah has a triple board program, but a triple board minded physician who's done, treatment, who's done additional training in pediatrics really sets the stage for working well with this patient population due to their medical complexity in addition to their behavioral complexity. We also have a team of LCSW therapists, and then we have behaviorists. So services include individual sessions, groups, medication management, in-home consultations and support, and there is a small number of ABA cases that can be implemented and administered. But as I said earlier, probably a majority of our patients getting ABA therapy get it from outside providers. And we make sure that we're coordinating with them. Sometimes a BCBA or RBT will join in person or virtual appointments to, discuss patient care. So to talk a little bit about how we see our program having strengths, it really is a unique care delivery. And, personally speaking, when I was looking for a job at the end of my training, there was nothing like home. There's no outpatient clinic that has combined medical and psychiatric services in one place. So, we're a co-located service. I can walk down the hall and knock on Dr. Jones's office in between patients at lunchtime and say, hey, Kyle, I've got this case, or we've got this case together. This is what happened today. Kind of get your thoughts about the situation. So, we're close. And one great thing is we have longer appointment times. So new appointments are 2 hours long, and then follow-up appointments are an hour. Really unheard of in this age of medicine and healthcare to have long appointments. And I think, the advantage of that is allowing the providers and the patients just time to get to know each other, and it sort of shift the focus of quickly being seen to prevention, to wellness, to, are we doing everything we can to keep a patient out of the hospital? And then often due to, how many other entities are involved in a client's life, I've had Zooms with 8 or 9 other people joining. So, there's a lot of people that we have to coordinate with. So a small percentage of our visits, about 5% when I looked at the data, about 5% of all of our visits are combined. So it includes a mental health provider and a medical provider in the same appointment in the same room. So, and I think those are for the most complicated patients. If you have a patient where that's the case, or client where that's the case, you can request that appointments be combined. And those are some of the most enjoyable appointments for me. I loved working side by side with Dr. Paul Carbone, sort of thinking out loud and really trying to get to the bottom of some of the challenging behaviors that the patient or the family were talking about. And so, that's incredibly unique. I don't know of anywhere that has the option of a psychiatrist and a primary care physician sitting in the same visit. As I've said before, case management, or, having intensive case management is unique. It's unique that our clinic is both a clinic and an insurance. And then we do have daily rounds where we talk about the patients who are in crisis, who are in the hospital setting, and we're trying to problem solve ways to get them out of the hospital, to increase their level of support by the time of discharge. I think another strength, I think this applies to many organizations. I think, we're passionate about these patients. We really love and care about them. And a lot of us are very familiar either directly or indirectly with the disability world. So here's our 8 case managers. Their caseload is broken down alphabetically. And we, they are such an important part. They're the communication facilitators, and we ask that they get to know their caseload, and so they may join appointments as well. They may know way more about the family situation than the providers do. Case managers help facilitate and create our treatment plans. So every 6 months, they're formally redone and then sent for approval to the physicians. Our case managers are asked to make sure that patients are making and keeping regular appointments, especially appointments such as annual physicals or medication reviews with psychiatry. Our case management team hopefully is aware of living situations of our patients and changes in it, as well as things such as guardianship status and helping, parents know what resources to go to start that process. And then they often are coordinating with you all, either for patients who have funded and are in services, or patients who have yet to even get on to be approved for the wait list, or patients who are on the wait list. Our case managers really are the interface with you all at DSPD, having direct conversations about patient concerns. They may contact the waitlist worker to share updates and concerns or to advocate. At times, our case managers may request that the client's case goes before the emergency funding committee. In some of the most challenging cases, they may coordinate with some of your supervisors about placement, and then they may be a part of the conversation or process in the rare cases of placement at the State Developmental Center. Okay. So this is a graph looking at, it compares the percentage of home program enrollees who are admitted to the hospital in their first and second year following enrollment. And so really, this is one of our data sets that we share about how the home program works. So, unsurprisingly, a fairly significant percentage of our patients do get hospitalized, but we see from the first year of enrollment to the next that there's a reduction. And really that's the goal, to reduce the need for hospitalization. Now, patients still need it even over time, especially with the highest acuity cases, but this is our message to the state. This is why we in part why we exist, to reduce costs. And it's going to be better for the patients themselves not needing to be in the hospital. Both the medical and the psychiatric hospital, those are not easy places to be. It can be somewhat traumatic for our patients. So this next slide demonstrates the reduction of need for emergency room visits. So again, between the first year of enrollment and second year following enrollment, the number of visits go down. Again, the emergency department is a busy, chaotic place. If they don't need to be there, we don't want them there. And sometimes you can get unnecessary workup and, put the patient through some stressful and distressing situations when it's not necessarily needed. Okay, and then a word about financial outcomes. So this is a few years outdated now. I need to update it, closer to this year. But the estimate in 2018 was that the average cost for an individual with developmental disabilities cost Medicaid in the state a little over $28,000 a year. Through the home program, that's a little over $11,000. And so, the bottom line is that the home program does lower costs and it offers high quality care at a lower cost. Most often our patient and caregiver surveys are positive, that patients and caregivers like having coordinated care, everything in one place. All right, now to shift, sort of mindful of our time here, but so the last part of this lecture is going to focus on the idea of, what does it look like to have good coordinated and collaborative care? So as a primer, information, health information is private. So, patient confidentiality is very important. So HIPAA, which stands for the Health Insurance Portability and Accountability Act, which became law in 1996. It's a federal law to protect patient health information. And as far as I'm aware, DSPD also follows the HIPAA standard for privacy. So HIPAA privacy rules ensure that patients have rights over their health information, including the right to get that, to make sure it's correct, and then to know who else has seen it. On my end, as a healthcare provider, I can share relevant information if the patient gives me permission, if the patient's present and doesn't object to sharing information, or if the patient's not present and I determine based on judgment that it's in the patient's best interest. As a general rule, I think to protect health information, we should share the minimum amount necessary. And there may be some circumstances that this comes at odds with advocating for someone. Now there are exceptions. There are, collateral information when it is okay to share when without like a release of information on file if imminent risks are in play. So imminent, acute suicidality or homicidality. But in general, we're going to want to have the patient approve and give permission to providers to speak to others. And just as a reminder, so many of our clients and patients have very little privacy to begin with. That's obviously a very nuanced and complicated subject due to, a combination of internal and external factors, the amount of care that's required. But, it's a good reminder for all of us to be considerate of this and to work to enhance privacy, enhance patient privacy. I always appreciate the group home agencies that encourage, the patients who are verbal and, who are their own guardian to make sure that that we as providers spend individual time with them alone to get an idea of what's going on. I think, their answers might be very different with 3 or 4 other people in the room. Okay. So how you as support coordinators can facilitate and coordinate care with the home program. So for patients who haven't joined yet, it might be helping the caregivers obtain that, the neuropsychological testing or getting access to the testing results that proves that they have a developmental disability. Please encourage the patient or their guardian to sign a release of information so you're authorized to speak to staff. That often happens when a patient joins the clinic at their first appointment, which is typically the medical one. One way to coordinate would be to attend an appointment. like I've said, I've had 6, 7, 8 other people in the room. We have to be very mindful of if that's overstimulating or if that's appropriate for the individual, or if we'll need the individual to take breaks or to maybe leave early and then finish getting information, just depending on their own needs or tolerance for appointments. You can coordinate with case managers in a myriad of ways. They share their emails. There's phone calls and voicemails that you can leave. You can also coordinate care by participating in team meetings that might be initiated on our end, or you guys might want to request a team meeting for the relevant providers. There may be times when our patients are in other settings, such as inpatient or in the ER. You might have outreach from a social worker in one of those settings, often to discuss the disposition. And so being available to coordinate and speak to those healthcare workers can be very helpful. When I asked the head case manager about this presentation today and what would she emphasize to say to you all, she would just say, please let the support coordinators know if they have a client in the home program that hasn't been seen for a while, please reach out. We're happy to get them rescheduled and get them going again. If you don't know whether or not your client is a home program patient, you can contact the case management team. And then, it does help if multiple placement changes have occurred. Hopefully they're still within our catchment area, but if they've moved outside the catchment area, our case management team does need to know that, both, sort of logistically, and then also so that we can make sure that the patients know where to access care in other parts of the state. And then often you as support coordinators are just, such an important team member at getting other relevant people to the appointments, whether it's behaviorists, whether it's, DCFS guardians or workers, or outside behaviorists. So what makes for good coordination? In part, I want to ask you all this because I think, it's so much of what you do. But, some ideas of principles that promote good coordination would be consistency, and with that consistency, making sure that you share how communication is preferred, whether it is email or voicemail or in person. Letting our team know is very helpful. Availability and timeliness is an important principle, being available when needed. The next principle would be coordination that leads to actionable steps. So what I would say on this is if you're communicating with our case management team about concerns for your clients, the extent to which you can frame your concerns in a question that can be actionable is one that's sort of more easily addressed. So if there's a medication concern, saying, I'm concerned that this client is not tolerating their medications or that they're having, too many side effects. I'm concerned that, there's some sort of possible medical contribution to the client's agitation, and I'm curious what the providers would say about that. And then, asking whether or not you think anyone in our clinic would have some opinion about placement issues, especially when we're struggling to find placements to stick. Other principles about good coordination is knowing resources. That's a massive one. I think I'm learning about resources like all the time, and I'm in my 9th year of working at the home program, and I feel like I learn something all the time. So yes, knowing resources and being able to share that with others. Then the next one, I do think there is a balance between, striking a balance, not under or over supporting. I think there's times where we can all be at risk of doing one or the other, and it's sort of finding the right, just right position. I think sometimes we might over support clients or or situations where we actually want them to, we want to facilitate their motivation instead to change or to get help rather than doing it for them. Like there could be skills that are lost if we over support and do things for them. With coordinating, making sure to reserve judgment until clarification is available. If there's something that feels or seems really upsetting about something that's happened in the home program, please reach out and try to get clarification first. We're definitely not perfect. We make lots of mistakes. We're learning as we go too. And so, and this principle, that's in play for us as well. Making sure that we get all the information before we maybe lash out inappropriately. With good coordination, being courtesy of the other person's time, I think is important. Everybody's very, very, very busy. It seems like our plates just get fuller and fuller and fuller. So being mindful of that, I think, is important with coordination. And then other principles include cultural competency, which is, the ability to interact with people from different cultural backgrounds in a respectful and effective way. This might be, advocating for the use of interpreters for patients who speak foreign languages. It could be advocating for a patient who is deaf to have access to an ASL interpreter. And then again, I keep bringing up the shared experience, the shared purpose. I think that makes for good coordination. I wanted to put it back on you guys now in terms of, what would you guys say about what makes for good coordination? When I was prepping for this lecture, part of what Rachel had sent was, how can support coordinators be more like the home program? And I thought, well, I'm not sure they need to be like the home program. You guys have your own ways of coordinating and you work within your own system. And so, I think we can learn from each other at all times. And so, yeah, I don't know what ideas do you guys have about coordinating effectively, how to do it? Seeing any hands, so maybe we'll save questions or participation for the very end, which we're almost there anyway. So here's a theoretical case discussion for us. It might sound familiar or not. So again, this is a theoretical patient, but so CS is a 35-year-old man who's new to your caseload with a history of early life adoption from an Eastern European orphanage, who is non-speaking but does have some functional signs. He has chronic severe self-injurious behavior and a history of chronic severe aggression towards others. Sometimes when staff attempt to block or prevent the self-injury from harming him is when the aggression occurs towards them. This individual is his own guardian. He's currently taking 16 medications, 9 of which are psychotropic meds. He has difficulty tolerating both medical and dental exams. He has difficulty going and attending a day program. And over the last year, he's had 4 different placements. So had a hard time maintaining placement. So where would your coordination start if this client was new to your panel, and how would you prioritize what to do? And then what issues and barriers would you anticipate encountering? Any thoughts? any hands up, and if there are and I'm missing it, I apologize.
People are commenting in the chat. They're too afraid to talk. So they're commenting in the chat.
Oh, thank you. Let me try to find the chat.
I commented in the chat because I can't figure out how to raise my hand on Zoom, so.
Okay, so Amanda Barr says, I'd love to talk to the family first and see what their needs are. I love it, going to the family first. So, let's say this client doesn't have family, or we discover that there was an adoptive family who decided not to pursue guardianship when he turned 18. Just to add to the complexity. But yeah, family first. Maybe there's a family member who previously, or you who might have new interest in becoming a guardian. That would be incredibly helpful in a case like this. How can we get someone to be able to approve decisions, medical and psychiatric decisions? All right, so let's see what else. Debbie Hong said, there's lots of meds prescribed. I probably have the team look at that. Very good. Yes, polypharmacy is an ever-present dilemma for the medical and psychiatric providers of these patients. Know that we're aware of it. In ideal circumstances, we don't want the patient to be on that many medications. If it's possible to therapeutically improve the situation by reducing meds, we want to do that. It's not always the case. It's not always possible. And so, but I will say just long-term, achieving a new stabilization can over the long term then better allow the providers to reduce the number of meds that they take. But yeah, these patients are at risk of being overprescribed medication, of having too many diagnoses given to them, but they also are at risk of not having enough, or some doctors would say, well, they should, they can't be depressed because they have an intellectual disability, but you absolutely can also have, major depression. It might look a little bit different, or might be a little bit harder determining it, but it's true. Okay, Ryan added, I would then see what documentation is that gives background information, diagnoses. It's great. And then Audra Stevens said, deep dive into historical concerns with and issues, reasons for meds, previous therapy, school records, environmental factors. Excellent. JC, I'm not sure if I said that. I don't think I said that correct, but I apologize. Go to the client and where they are at, get to know him, talk with them and their families, and ask what their biggest concerns are, started work from there, and focus on safety concerns. I love that, just getting to know the person, going and meeting them, directly addressing them, greeting them, speaking to them, yeah, what a powerful and such an important place to start. Okay. I'm gonna see. Lost my PowerPoint. Let's see if I can get back to it. Here's some ideas that we would be considering in this case. So, do we or not need to advocate for a guardian? Again, if you're contacting potential family members, that's a place to to potentially find a guardian. In rare cases, we may think or want to advocate for a public guardian. I know that's a very, very limited resource, but it is still really important in many of those cases that we potentially look. And you guys really are the people that take the lead on that, contacting the office OPG, I think is Office of Public Guardian. And a lot of these things are things that you guys said, trying to get the client in for a medical examination to rule out common sources of agitation, like chronic constipation, gastroesophageal reflux disease, headaches. Dental issues can be a huge source of distress, and then medication side effects. Do we want to refer the client to a behaviorist to complete a functional analysis? The behaviorist, all behavior is communication. And so, are we more carefully thinking through antecedents, what's happening before the behavior, and then a description of the behavior itself, and then what happens as a consequence of it? Those things all influence and play a role in whether or not a behavior is more or less likely to continue to occur. In a patient like this who's non-speaking, nonverbal, but uses functional signs, is that a way we can enhance his function? And, I've seen time after time, when you get more functional communication, you get better toleration for frustration. And so, you're giving them language, you're giving them a better means of accessing their needs. So, do we want to refer this person to a speech therapist? Or, other ideas, is the patient just too acute that we might need to consider psychiatric hospitalization? For everyone's information, it's much harder in the last 5 years to get a patient placed in a psychiatric hospital. There's fewer and fewer beds since the pandemic. It's been very challenging. And so we still do advocate, and there are times when safety is so imminent, safety concerns are so imminent that the patients do need to be admitted to the psychiatric hospital. But that the overall landscape has been more challenging the last 5 years. And so, just know that it's a struggle for us, even in the patients that we clearly know need to be there, but we don't necessarily know how to get them in the hospital easily. For the failed, day programs, is this client, should we try advocating for more one-on-one during the day, more of an individualized approach? Were the previous placements all in a traditional group home, and should we consider a host home placement? And then, is this to the point that, you want to think about speaking to your supervisors, potentially reaching out to the Utah State Developmental Center for placement? In my time at the home program, I'd say maybe 1 or 2 cases a year. Consideration is given to placement at the developmental center. Now, sometimes several years later, those patients are able to come back into the community and receive services again. But there is a small percentage of patients who do end up needing that long-term level of care. Okay. Then wondering if there's any cases that you guys wanted to bring up. Again, not disclosing anything specific if it is a real patient. Lastly, you may be wondering who is a good fit for the home program. So if you have this question, please ask. Hopefully this has been addressed as I've given this talk today. Again, as I mentioned, the transitional age is typically one of the most common times of enrollment. I talked about some potential hangups on joining the home program if the client really, really loves their current primary care provider, or if they want to continue seeing their long-term therapist in the community. Even location is a concern. If you have a client who lives at the southern end of Utah County in like Santaquin, getting to the home program, especially if there's bad traffic, that might be a several hour each way difficulty. We do offer televisits, and so that is a great tool that we now have, and has allowed us to see a number of patients who we really struggled to get in regularly. In some of those cases, we in the past had to get really creative. Do we just sort of do a drive-by visit? The provider goes out into the parking lot and, says hello for a few minutes and talks to staff. The virtual appointments let us see the clients in their native setting. I love that. I had a patient who never spoke to me once. She's verbal, but just they were sort of selectively mute. And the first appointment during the pandemic on Zoom, she was sitting in her favorite chair. She was holding one of her pet cats and petting her cat, and she answered questions. It was amazing. I was sold on Zoom and virtual appointments from that point forward. And then lastly, if your clients receive current behavior services through ABA providers, they can continue to see those providers when they join the home program. We do have a very small capacity to take on ABA cases. We do a lot of behavioral consultations, several of the BCBAs that work at the home program, looking, how do we triage acute issues? Do we consider a functional analysis to determine the function of the behavior? And empower the caregivers to keep doing what they do, provide some parent training, among other things. And here is the handout for the home program. At the bottom, there is a phone number, a Medicaid phone number to start the process if you have a client who might be interested and meets eligibility criteria for home. 801-538-9164. The person there is named Helen Joy. She works at Medicaid, so she doesn't work for our clinic, but she's the intake person, and then gets in touch with our intake team and starts the process. Right now, our wait list is reducing. We've had quite a long wait list, in part because we've been down 4 or 5 providers, but as of the end of December, we are back and fully staffed, and really love this crew of new physicians and new providers who have joined. And here is a picture of the group. And that is it. I want to thank you all for the opportunity to present this today. Lastly, let me just express appreciation for all that you do as support coordinators, for the way that you change your clients' lives, for how you advocate for them, for how you care about them. I appreciate what you do on a day-to-day basis. So yes, thank you, and appreciate coordination you may have with the home program.
Awesome. Thank you, Dr. Stevens. Again, if you all could just go ahead and fill out that survey, especially if you want credit from the Utah Social Work Association or certificate attendance, that would be great. If you have any questions, I'll stay on for a few minutes. But otherwise, again, thank you, Dr. Stevens, for your time, and I hope everyone has a great rest of your day.
You're welcome. I do want to address Debbie Hung's question, how long is it currently taking to get into the program? So I'd say on average, we're about 2 to 3 months to 6 to 10 months right now. So hopefully we'll get that wait list down to nothing. So thank you, everybody. Really appreciate all that you do.